All right. So I just decided to do like this week's meeting on like what I've been learning and like having meetings on with Tom, just to like help it kind of like ingrain in my brain, so I can like learn through it, and then teach you guys just like the very basics of the human matrix of Zach Couples. Man, this is small on this computer. Holy cow! All right. So kind of like the main thing with the human matrix is kind of like these equations. The top one being eccentric equals expansion equals inhalation equals flexion, abduction, and ER. And then kind of vice versa. So concentric is compression, is exhalation, and then is extension, adduction, and IR. And so that's kind of gonna be, jeez, I'm battling a cough. All right, is gonna be the premise of this whole presentation, which is kind of the basics. So the first, we're just gonna go like as the equation goes, we're gonna follow that through for the entire presentation. So again, eccentric and concentric. So very simple. I mean, we should all know what that is. So like the eccentric is like the muscle contraction where the muscle is gonna lengthen, and then concentric is the opposite. So during the contraction, the muscle will shorten. And then just kind of an example, like the lowering of a squat, or of a bench press, when you're bringing it in, is going to be the eccentric motion, and then standing up or pressing it up will be the concentric, to put it like simply. So then the expansion and compression is next. And there's a little bit more to both of these. So when I think of expansion and compression, I think of an accordion. Like it just like clicked with me to think in that way. So expansion, being able to drive air or like the internal forces into certain regions. And to do that, you need to be able to eccentrically load in that region to get that expansion that's desired. And then compression would be like an increased tension in the area. And if there's anything that like is kind of off, or you're like, oh, you didn't really get that, just let me know. This is kind of what I took, the notes, like kind of from the notes I took from the human matrix, and then put them in to here. But compression being like an increased in tension in that area, and you need like to be able to like concentrically fire those muscles in order to compress. So if you think like an RDL, I think this is an easy one with expansion especially, because often if you see somebody like when they're pushing their butt back, they'll like hit a wall if they can't expand back there, like posteriorly. So if they're able to sit back throughout that, like the motion of the RDL, that would be considered like in a posterior expansion. And then the opposite with the compression, being able to extend and like squeeze your butt, shoot your hips forward. And I'll get more into the accordion a little bit later. So, there's the big letters. Like we hear like Tom often say, like a compressed individual, and I think, I mean, just me personally, like I didn't know for a while what that really was, like, or it would say like trained individual, and I think it's just like it's a lot of tension, like in those areas. I mean, depending on like your ISA, but it's a lot of tension due to like just constant and like repeated like concentric activity. Would you say that's fairly accurate?
Force production, yeah.
Force
Which is
production.
like, concentric is force production, like, but it's like your global like ability to produce force at a high velocity repeatedly.
Okay. And so that concentric or that force production, and that, like along with like compensations due to axial skeleton like orientations, injuries, or like whatever else. And so like a compressed individual would be like a JT that we see walk around, or like a Michael Bush, which like when you talk compression and expansion, it sounds like compression would be like a bad thing, but like they're two of our best athletes we have like walking in our gym. So like that's kind of like leads you to the question, like what do we want? And it completely depends on the goal. And here you can see it says like a power lifter, like you want to be like very compressed. And like we've talked about this quite a bit, like just have enough range of motion to do those 3 big lifts and be able to load them up as much as possible. Where if you get a middle-aged mom that comes in here and she's in pain, you want her to be able to, like I think of it as play every note on the accordion, like expand all the way out and then compress in depending on the needs and throughout the entire body. So then you have on one end of the spectrum with powerlifting, very compressed, and then one like a middle-aged mom, very like able to move and compress and expand as we want. So what's ideal for an athletic performance for like the athletes that we're going to coach? And I think I took this scale from Tom's old presentation. And his was more on like the tendons and like ligaments and like the yielding overcoming principles. But I think it ties into this very well with like the rigidity and being more stiff. Like I would see that as like more compressed and then like elastic or like less stiff, like able to like expand. Like the elasticity being able to like absorb or yield like eccentrically, and then the rigidity to get out of those positions. And so you want an athlete to be able to do both of those. So like you want to reduce the risk of injury and so that they can get into the positions that their sport entails and requires of them, but you want them to be like as rigid as possible while being able to get into those positions, because that is going to drive like the ideal performance. And then I think that just like ties in also with the like the diverging roads of the performance and health and kind of how to go about that, and just understanding that they do at one point are gonna oppose each other. So now into the inhalation exhalation. So the inhalation, that's, I mean, obviously like with the equations, it equals, or it's the kind of the same as expansion, and we desire a 360-degree expansion. And the inhalation is just like an increase in pressure, like air that comes in obviously to the lungs. And so what like your like abdominal and like thoracic cavity are doing, like they need to make room because they have like your guts and your organs, and they need to make room for the air that's coming in. So the pressure is going to overall is going to increase. And then exhalation would be compression. And so that I like to think of it as like the space kind of opens up, like the air is going to leave the lungs, and so then your guts and your diaphragm are able to kind of replace that air that was in the lungs in an inhalation, so that need for expansion isn't there, or the pressure from the air is no longer there. Oh, I have a little point on here. So like from a health standpoint, if you think like the pressure building up in an inhalation is inevitable with each breath that you take, then like wouldn't you want to like manipulate position and like your muscles so that with that inhalation and that like the loading, like you'll be able to like eccentrically expand in the right places, if that makes sense. So like I said, like if you're going to get expansion through an inhalation anyway, wouldn't you want to put yourself, and that's kind of where you go into like resets, in a position to where you're going to drive ranges of motion that you don't have?
Can you give us a specific example, please?
Yeah, so if you're doing, let me think of one. If you would do like a hook lying with like a low reach, for somebody that doesn't have like ER in their shoulders, then you would get them in the stacked position so that then they're able to expand be down. It would be upper back, lower back. So you'd be able to expand lower back, so then it would drive the ER back into their shoulder. Just because of the position they're in, their inhalation, the need for expansion, they're gonna drive desired motions.
What are you driving with the lower body there? In the hook line. The hips.
You drive ER as well, wouldn't you?
Mm-hmm. Would you know why?
No, because your hip angles, right?
Yeah.
Is that 90? Well, it depends.
Alex, lay down real quick for force, will you? Instead of the hook line position.
Oh, that'd be. Go ahead.
No, you go ahead. It's your presentation. What
because
relative angles of his hips, right?
60.
Yeah,
60,
right.
because you're driving 60.
And so what's happening at the sacrum there?
Counter-rotation.
Boom, right? So counter-rotation is your direct inhalation ER measure.
Mm-hmm.
So because he's in a counter-nutated position at that level of hip flexion, that's also going to bias the ER as well.
Yeah. Okay.
So, does that make sense?
Yeah. So like 60. I mean.
You can stand up. Okay, cool.
That because it'd be like 60 degrees. Would that tie in with like the early propulsion and stuff?
Yeah, right. Because what are you doing with the low reach? Is effectively you're reaching at 60 degrees.
Yeah.
Or like 0 to 60, depending on how much limitation you have. And so like and when you do a low reach and hook line, your thoracic like your ventral cavity, and I guess your pelvic diaphragm and your thoracic diaphragm are, if they're stacked atop one another, that's going to bias those areas that you talked about, right? So it's going to be below the level of the scapula and below the level of the trochanter. That's going to eccentrically bias those tissues to expand.
Okay.
Whereas now if you bring them up to 90 degrees for either one, that's going to be a different bias for a different action, right? So if you were to do like a 90-degree reach or reach straight up to the ceiling in that case, then you're still gonna get lower expansion at ER because you didn't change the hips, right? If you're still on the hook line, but you're just doing a forward reach, that's gonna be ER the hips, IR the shoulders.
Yeah. So and then vice versa, if you put your hips at 90,
boom,
in your arms. Okay.
Yep.
So the thoracic diaphragm is just like a very like brief intro to it, but as you inhale, like I said, it's going, your cavity needs to make room for the air that's coming in the lungs, so it's going to flatten out, where as you exhale, the air's gone, so it's going to replace that. So like right in here, it's like where your guts are going to sit, and they will move up and down according with the diaphragm. Then you also have a pelvic diaphragm, and so in an ideal situation, your thoracic diaphragm and your pelvic diaphragm will match. So as you inhale, you would want them both to descend, and then as you exhale, both to ascend. But through compensations, through compensations, it's very common to see that flip, so that their opposing actions, so like as the thoracic diaphragm is going to ascend, the pelvic will descend, and vice versa. Now into the motions.
Does that make sense?
Can you tell us why?
No.
So here's a good example back to one you already referenced, was like, think of like a narrow ISA, right? Why are the ribs so close together? Can you go back one slide? So like look at these on this inhaled one, like look at these attachments, right? You have on the front, it's at the lower ribs, and at the back, it's on the lower back. Okay, so if we think of something like an inhaled as a flattened or a descended diaphragm, the compensation often is that actually descends, and because they're inhalation biased, they're always trying to get air in, they actually almost descend it so far so that because of that attachment set on the lower rib cage, it pulls the rib cage down and in and makes it narrow. Okay, but at some point you got to produce force from the ground, and that's going to be relative to your pelvic diaphragm being concentric, right? Because if I don't concentrically orient my diaphragm upon any foot contact, I'll crumble into the ground. So you get this this really low.
So you more often have to engage the pelvic diaphragm because you're so.
That makes more sense to me because it's like he talked like if you think about like a secondary compressed narrow infrasternal angle, so anybody, any three of you, right? Like you guys can't really expand lower, right? You guys all pretty much have a loss of ER and IR everywhere. So you're going to be biased more towards compression in that sense, but you're still narrow. So it's think about this: if I get a pelvic floor that's pushing up, or a pelvic diaphragm that's pushing up, and a thoracic diaphragm that's pushing down, I'm creating this pressurized zone in between it where I'm literally pushing either guts and fluid or air all into this little compressed compartment. That's where you're going to see this enormous amount of probably compression, I would imagine, in people who are kind of your more athletic, speedy people, right? They're super concentrically driven, but they're still narrow, right? So they're not this traditional wide ISA who's a force producer, but through training, they got stuck in an exhaled rib cage situation where everything kind of where how they exhale is a dissension. So rather than inflating it up, when they exhale, it actually just goes further down. So that's their cheat. But you still have to get the other thing to ascend in order to produce force. So
would you for example, would you say JT is more of that camp variety? Just
that would make sense
because of years of training and
yeah, right. Because he's good at producing force, but he's narrow as all get out. So in my mind, that makes the most sense to me. Where it's you have a pelvic floor coming up, you have a thoracic diaphragm that's going down. That allows him to be incredibly stiff when he needs to be most of the time, but he just doesn't have a lot of give. And that's where
so the thoracic diaphragm would descend so much. When would it ascend? Or would it just would it be
that's why you need to probably intervene with something that's going to allow him to teach him how to ascend it.
Otherwise it's just kind of stuck.
Stuck, right? So his inhalation starting point, when he breathes in, he's getting to that point, but it never really ascends.
Okay, I knew a narrow is more biased to a descended diaphragms, and then vice versa. But
and obviously that doesn't mean he can't breathe. It just means there's a compensation in there somewhere.
So you're saying this would be his exhale position, basically.
Yeah, right. And his inhale position would be even lower than that.
Okay.
So when he exhales, he starts from a low diaphragm to a flattened instead of a domed to a flattened. He domes upside down.
Huh. So how I mean, when you listen to Bill or Zach talk, they make it seem. Because I went through and rewind it 5 times. I'm he's not really telling me the answer. Why it does, why there's a compensation there, and that it starts to do opposing actions. How long would a compensation like that take? Over years of training, or is it
Oh, sure.
Yeah.
I can tell you. My guess would be probably through training, right? Because if you inhale and you squeeze it.
Yeah.
You're compressing down for a narrow, it's going to be down here. For a wide, it's going to be up here.
So when we have athletes come in that are untrained, you assume that they're mirroring each other.
Well, the table will tell us.
Yeah.
Right. So if I can get, if I assume if I check their ISA and I'm in their inhalation bias, so they're narrow, they should have full flexion in ER, or they should be biased towards that.
Yeah.
So you assume if their ER measures are there, then then they have the full excursion, and they're able to breathe fine, and they're able to expand where they need to expand, and they're compressed where they need to compress.
Yeah. Okay. So the motions. So how do they go together? Well, they can't not. Yes.
There you go.
This one got me when I was sitting there right now. I was this is a good one. a good little saying.
Real zinger.
So, yeah. So
Zing.
so like Tom often will use like the bench, I think, when describing this, and that makes the most sense to me as well. Like if you just think like eccentric, like flexion, like happening out at the elbow, and then like you are just naturally gonna abduct in ER, and then vice versa in the concentric with like extending the elbow, adducting, and you're just naturally gonna come into internal rotation. So just kind of like a continuum, like you are just always doing those three things. So if you do one, you're doing them all. Kind of.
You're doing it correctly.
If you're doing it correctly, exactly. So I mean, the question with that is like why? When it comes to those three motions and being eccentric, I like to just like a little like study tip that was for me was just kind of like get away when you're talking like eccentric, like it's abduction and ER, like you're kind of like working away from that middle of the body, and then the concentric would be more of like the eccentric is kind of like I think of it as like a loading phase type thing. So if you're like you're lowering into a squat, that's the eccentric portion, kind of loading, and then once you get to that bottom, like it's a quick stand up into that concentric phase, which would be more of like a force production. In there, I just kind of think like bring it in, and when you think, whether you think like medicine ball, like a chest pass, or like sprinting, or just like when you're taking a step, like what is going to produce the most force or the most power, and it's going to be like stuff that's going to bring you closer to your body, like that's where you're going to have the like more power. So it makes sense that adduction and like internal rotation is going to lead into that, and why you're going to be biased to do those motions together. Is there a question there? You look like
No, I mean, like, I just think another way to even simplify that further, just for like everyone's sake, would just be like, you move from expansion to compression, right? So it's like an eccentric forward phase is like you are expanding to get depth, and then you are compressing to return back to center. That's just another way to think about it, but like that's easier to think about, right? Because like we can't move into compression, like you said with the hinge example, like you will hit a wall.
Yeah.
Where you like everyone expands and everyone compresses. It just isn't authentic, right? So if you get someone who hinges and then but like as soon as they hit a certain point, then you see lower back start to come up. That's how they're expanding. They're expanding. They're just not expanding where they should be.
Yeah.
And so like for like an eccentric portion, like you're just looking for where's the expansion coming from versus like we know it's happening because it has to.
Yeah.
And it is eccentric in nature. That's like the bias of the continuum. But then then when you bring it back to the middle, like that's a good way to put it. Like you're kind of like thinking like move into space, move into expansion, and then move out of that by taking space away.
Yeah. So we kind of mentioned this briefly, but like the ISA and the IPA, and we all know what both of those are. But like, why do we use those as measurements? That like, I mean, that's like the telling sign of what somebody's gonna do and how they're gonna test. If they're like a true like just have primary like compensations, and it's just because there's less ways for you to compensate at those areas. So if you were to just test flexion or just test like in like external internal rotation of like the appendicular joints, like you can compensate there, and we see it in like all of our athletes. So that is gonna there's less ways to kind of hide your like authenticity in movements. 90 degrees or less than 90 degrees is an arrow, over 90 is wide.
What's IPA?
IPA is, so that's just mirroring, it's what is the pubic symphysis, right?
Yeah,
the angle,
infrapubic angle.
Infrapubic angle, yeah. But it's the angle at the pubic symphysis.
Yeah, and so if you look at the slide here, even these are really good pictures, like all the dark stuff on the ribcage, it's all just cartilage, right? And so because if we look at like that diaphragm picture initially, like the attachment points, like we said, like if it's wide, those are gonna get pulled apart, cartilage like that adapts way easy. It's way easier to bend that stuff than bone. So like that's where the first place people will cheat is the rib cage, and then like even in between the pubic symphysis, you can see on my pelvis model up there if you want to grab, but like this, like in between there, like there's also a huge ring of cartilage that separates these two innominate bones that come together to meet at the pubic symphysis.
So that will
that also has a ton of give in it just because it's made of cartilage.
Yeah.
So like the cartilage is like your first compensation, which like kind of then tells you what people should and shouldn't have and like what order to restore the losses of motion based on their angles.
What would like the next compensation be? If the cartilage would be the first, then the actual like
that's your primary compensation, right? So it's like my primary compensation as a narrow is things narrow down. I get tight on the front side of my body and I lose all my exhalation measures. And then if I'm wide, I'm eccentric, I'm concentric on the back side of my body, which means I lose all my inhalation measures.
Yeah. Okay. So what do the ISA or IPA have to do with all this? And it just allows for optimal performance, and it rules out the axial skeleton as being like a limiting factor in health or performance, whatever it is that you're driving. And then the ultimate goal is to get the angles to go from, or like to just like to be dynamic. So as you inhale, it's going to widen a bit, and as you exhale, it's going to narrow. And so that's why when you're given a wide ISA, you do resets or training and manipulate certain things to get them to narrow, so that when they exhale, they're able to narrow. So I think ultimately you just want that dynamic angle at both the ISA and the IPA. Okay, what I just said. So like, how would you go about doing this? And I would say like through training, if you can, like before you would go to the extent of hitting a reset before you train, try to tackle it in their training, through putting load in different places, making sure they're in the stacked position, like the angles of pull, from like understanding like the muscle fibers and like the angles of pull, and if they're narrow, what does that mean for like the external obliques or wide, and then the cueing of certain like exercises. So we've seen like if you do a split squat, you can coach that in so many different ways, looking for different outcomes and ultimately driving ranges of motion or an improvement in ranges of motion to recapture those.
Wouldn't you want to educate an athlete?
Would you want to?
Yeah, would you want to?
I think not necessarily. I wouldn't think so. I think if they're looking to just improve performance, I think if you toss them in, like in these pictures, you see like you're just tossing a dumbbell in one side or the other, and that's gonna drive, like for this guy up here, that's gonna drive like an external rotation. Forget like the propulsion stage and stuff. I was just trying to show, if you put it on the outside or the ipsilateral leg, it's gonna drive like an external rotation. So I don't think they necessarily need to know that. I think if you can recapture it without them knowing, that's fine. I mean, unless they're looking to.
What if they have like recurring injury in their sport? And it might be because they're compensating and they don't know why. And
yeah, I would.
Like someone's kicking a soccer ball and they don't set up properly for it, and they end up like, oh, my back hurts.
Yeah,
I do that every single time.
Mm-hmm. Yeah, I mean, in that case, I would say like for sure. Or if they come in and do a reset and then they're good to go for training, and like with like Charlotte the other day, like she came in super tight adductor, and then when we tried a couple different resets, we got one that really worked. So if that's the case, it's like, hey, hit this, like, because when you kick, something's off, just do this reset before and you should feel better. But I think it was said yesterday, like don't, once they come in here, reset, train, and then they go and the next day to go to soccer practice and they just think that they're gonna be good to go without doing any reset. Like it's probably gonna hurt because it's an acute like response, like a reset or.
Yeah, you gotta be careful with that. I think just because like some people have like if someone is like pretty mentally fragile, and then you go ahead and you tell them they're more fragile than they like really are, that can almost be like a detriment to them. But if it's someone who's like
Compounding issue.
yeah, right, like if they're pretty, like if they're squared away between the ears, like you can probably be like, hey, like this is what you have going on, this is trying to rectify that, and we're gonna do this every time because like this will like ultimately get a permanent change with practice, just like anything else you do. So that's like, it just depends on who you're coaching and like what the situation is. That's a good question.
Yeah. Is that a conversation you had yesterday?
Yeah, just
Kind of.
just a overall picture, like, are we trying to get everyone to understand fully what we're doing? Not necessarily. I'm just teasing that out. Like,
Yeah.
how do you approach it with each athlete?
Yeah. Would you say it kind of depends?
Yeah, like
Case by case.
it like is like we're like I tell people all the time, like this is a different language, so it's like how much do you really want to like interpret this to somebody else? Like I didn't need to tell Charlotte like, hey, we're trying to get you back some internal rotation on your left leg and external rotation on your right leg, because that's going to offset the load on your right adductor and balance you out more. She'd be like, what? Like why?
I don't think she would care.
Yeah, right. It's like does this feel better? Cool. All right, now you just got like now you see how much this helped in like 2 minutes. So like, there's your buy-in. Like you just got a result. Like they trust you. So it's like okay, like if you need to further that conversation to build trust, I think like if you think of like an adult, right? They probably want to know more. Doesn't mean we tell them everything, but it's like ultimately like you're trying to get a favorable outcome for their benefit, and so like you tell them what they need to know to like perform it correctly and like get buy-in. But oftentimes like if you get someone who's younger who just needs to, like who just wants an immediate kind of response, like it's usually enough.
Yeah, and that's kind of what I was trying to hit with what we have going on here too. Just putting the load in a different spot can provide an outcome more than just if you're like in this case, if you were to put a dumbbell in both hands, you know, you're not going to essentially drive and get an external or an internal rotation. But if you have an athlete where there's like some pain, if you can just make it unnoticeable to them and just just put it in your other hand and you'll be set, then you're driving a desired outcome that will ultimately like improve performance and health. We pretty much talked about these. Just like it's an acute response, and this like the skeletal orientation, allowing for like that stack position for your training. I threw this in. Kind of like Tom had mentioned earlier, like a narrow is gonna be more compressed, and like concentric, like bias, more concentric bias anteriorly.
Why?
It's because I got fly right there. Because of the pelvis.
Oh.
Because because they're more counter nutated at the spine, so they're kind of at the pelvis is telling them that, like they have like a spine almost going backwards, so they need to compress anteriorly so they don't fall over.
Mm-hmm.
Whereas vice versa, a wide is going to be more nutated at the spine, pretty much putting them here, and then they're compressed posteriorly so that they don't fall over there as well. So ultimately, like this presentation was to use these equations to determine the best way to serve our clients' needs. They're based off their needs and their goals.
Mm-hmm.
That's all I got.
Awesome, that was really well done.
Thank you.
You got any questions, Alex?
I mean, not really. I'm still soaking a lot of this in. Like,
Oh yeah, me too.
it's been like kind of wash over me in the last couple months through you, through
Yeah.
everything. thing, and I don't have any specific questions.
What are like some actionable takeaways then that we could take to this and maybe either implement right away or like add a tool to the toolbox, right? Like how does this help? This isn't for everybody, right?
Yeah.
We can answer this. It's just like, because like the theory stuff is great, but it's like we don't like, we can sit here and talk about it all day long, but then it's like you get someone in here, you have no idea what to do because like they're a complex human being with 12 different super systems within their body that we just don't know how to manage. So
Sometimes it's like the eye test with some of those individuals, like when you see like kids, I think of like Paige Visser and like usually super like valgus and like all those kind of things, like just the way that they're presenting, like in their body orientations, like when she'll go and do a split squat, if she's not doing an ipsilateral hold, she'll be super like interiorly rotated, right?
Yeah.
Internal rotation, and so like just being able to identify like what they're doing and what that quick like assistance would be in order to put them in a better position.
Yeah, I think the biggest thing that I see and like how all of this stuff helps separate this gym is like when people come in with pain and like they know they can come see you, and like not that you're gonna like just fix it, like you're not some like magician, but that that they'll like more than likely they're gonna come in here, hit like some resets, do something, and that they'll be able to go out there and train so that this day wasn't like wasted. You know, like they didn't stay home, or they know like if they, one thing, like they feel comfortable coming with pain. Like if they're like, I can't go to that workout, they come anyway, and they know they're still gonna get some work in. And that's kind of, I think if we can get all coaches like up to your speed in that, I think that's huge. Like that's one like my goal like, right now is like I want when an athlete comes in with pain that it's like, yeah, you can go see Thomas because like we know you know the stuff, like, or you can go see Colton because he knows what he's doing too. Like that, like for me, like that's how I'm driving myself, and that's why I like really want to dive into this stuff.
Yeah.
Because I want to be like, oh, like you got pain, all right, go see like one of them because either one will get
Just
you.
walk in the gym. Doesn't matter who's here that day. We're gonna help out.
Yeah, exactly.
Yeah, I mean, because like ultimately we're just trying to like just monitor would be like a really good word. Like we're just trying to like, because we like obviously performance is like the act of like deliberately restricting certain ranges of motion so that you can be really good at one thing, right? Powerlifting is always a great example of this, right? Because it's like it's just pretty cut and dry. There's just not as many measurables for say like baseball or something like that. So it's like determining what's important and then having these tools to be like, yeah, like okay, maybe I am getting like super tight hamstrings to super tight quads from like being so strong and fast and I'm so anteriorly oriented that like bringing me back just a little bit might just relieve some of that pain. It's a good tool to have, no question. And like you said, like do we need to go like fixing people? Like no, like because like part of the reason they're so good is because they're probably biased at what they're good at. But then we get in this topic of like these like overuse and overloading and just like kind of like a pain sensation or like what the brain's taught, like what the brain is and the body are communicating to each other. Sometimes you just need to provide like a filter, like buffer that out by like just providing like some sort of like axial relief, I would guess.
Would you say like it would be you driving performance and then like you said you get like a pain tightness in muscles, whatever it is, and then you would kind of want to like reset that so that you continue to drive performance until it's like detrimental, I don't know if that's the word, but like to their health, and like then like until it starts like really affecting them, and then you kind of diverge into like more.
Well, I would definitely say like performance is like pretty detrimental to health. For a good reason, like, but the way I think about it is like if you want to think of it from a long-term scale, it's like how many of these kids are really going to go pro? 1 in a million. So like it's there are other consequences we have to think about, right? Like we get into our ages and we're like, I look at myself as an example. I think this is like what drew me to this is like I trained hard my whole life, and that like didn't negate like and hard work's good and like output is good, but it's like I am, like we talked about last night, like I'm reaping the consequences of my 16-year-old self.
Yeah.
From like wanting to be so dang strong. And so I'm like strong enough to be dangerous to myself. And so like finding ways to, like when you get in a certain spot, like if you, it's kind of like we talk about like microdosing, like sprints, right? It's like you need to have a base in order to get a benefit from like a microdose effect.
Yeah.
So it's like, for me, it's like, I never had the base of a movement options or like variability. So now most of my training is just trying to restore that because I am 6 years behind the curve. Whereas if we can introduce this stuff in small doses and give them a taste of it so that they can adapt to it to a degree, but it's not that burner's not all the way up. That's like super low. We're just kind of keeping an eye on it and just like, hey, like I want your body to be able to do this. Just so like in 2 to 5 years from now when you're not doing anything, it's like you just don't hurt just because you pushed yourself so hard without like taking away all the options.
Yeah.
In their movement.
Yeah, I think that's a really good way to put it. I think I've asked you that question like a couple times. I think that was your best answer.
Oh, thank you.
Repetition.
That was a good one.
Yeah, I mean, I think the more you think about stuff, the better answers come out for sure. But, like you did a good presentation. Like I wouldn't have probably thought about that if you wouldn't have whipped this out. But yeah, that's ultimately I think the goal with this here. Like, and so that's why adult training looks the way it does, because it's like you're just undoing their crap.
Yeah.
Whether it's work, like sitting, whether it's manual labor jobs, you're pouring concrete all day and you just hurt everywhere. Like it's just like their training looks different because it's like in order to even get benefits out of training, it's like we can't squat. Like that takes a lot of exercises off the table, and that takes a lot of range of motion off the table. So it's like even just restoring the gradient for people to move, like that gives them the option then to pursue whatever fitness goals or composition or aesthetics they want. But like you need to get that in there first, I think.
And pain free, which is huge.
Yeah,
that's
100%.
I don't know if it was. I think it was Zach's one of his like breathing videos he put up, and he was just talking how pretty much like, well, why is breathing important, like respiration? And he's like, because it's like a prerequisite. So like when you take like the adults out and you literally just have them breathe the correct way, like on the floor, and then that is a prerequisite to like a reset, which is prerequisite to like a stack, like holding a stack position, like, and then like during movement, and then during like movement and load, and it just everything like builds into like a prerequisite to something else, kind of thing. Yeah.
Gotta breathe, otherwise
you gotta breathe.